Okay, we're gonna give it a run again. I got another microphone. We'll see if it works. Don't know why the other one is not. If you could just let me know if you could see me. I don't have everything here. All right, let me know if you can see me here. If you can hear me, even better. That would be wonderful. And then we'll get some Q&A done. Spend a little July 3rd together. Right now my docs aren't all working, so I can only see the chat. There we go. Great. I can't see how any of the streams are doing. I can only see the chat. Great. So I got an audio. I don't know why. I had to restart my computer. And here's what we got. So we're here. All right. Hey, everybody. Farazuk, Jules, Gwen, Nomad Over Normal, Eileen, Doru, Nicholas. How's it going? Good to see you guys. Hey, thanks for being here. We got a big holiday tomorrow. So I don't know what you guys have been up to. Maybe you're getting ready to do some grilling. Farazuk, let's get you on an American 4th of July tonight, or tomorrow, excuse me. And let's have some fun. We have had an interesting week in the clinic. Susan's cured. She can hear me now. Oh, from the massage table. Very nice. So we had an interesting week. So we actually, a couple times a year, when we take a break from the clinic, we don't take like a Memorial Day off or a 4th of July off, because taking one day off when people are in from out of town makes it hard for people to get treatment. So the way we organize that is we will take, a couple times a year, the whole clinic takes a week off. And usually that means I end up working on stuff in the clinic, and this year is no different. So this is just a little bit of what we were doing. We've been up to the last couple days. This is me. It may not seem like much me, but this is me and my dad. That's Dave Keiser right there, extraordinaire, always a helping hand. And then my good friend Arco, my Dutch muscle right there. And these guys are helping me carry this base. And what we did was we actually have a new whole body rotational chair. Ours has been wonderful. We love it very, very much. But we saw an opportunity to take advantage of getting a new one, which is pretty cool. And also, ours has lived a wonderful life, and we, as you can see here, have started the process of letting it break down. So this is me and my son today. He took this picture for me, and we are taking this one apart, which is wonderful, but we have been working our tails off. So it's like 14-hour days. So we're coming straight from working on these machines to being here, which is like a different mode than I'm normally in. But here we are. Let's ask and answer some questions, and then we'll let everybody get rocking and rolling. So let's start in here. We've got Austin, and what I'm going to try to do is, I've noticed that in my desire to try to answer everybody's questions, sometimes I end up rushing through some questions. And what I'd like to try to do is maybe give myself a little permission to try to go ahead and go a little more slowly, try to answer some of the questions with a little more depth, and see if that doesn't give us even more opportunity for goodness here. So let's see. So Austin asks, I was recently diagnosed by a chiropractor as having 2 inches plus of forward head posture, a locked thoracic spine, and compression of the atlas. Okay, well, Austin, that could be true. I don't know, but let me know if you have any questions. Also, the good time to do the weekly caveat of, I can't take any, I won't answer any specific medical questions about a specific case here on the internet. We don't do that in chats. That's just a good rule of thumb. So that is the rule going forward. Could correcting these possibly resolve some POTS symptoms without any further intervention? I have no idea. It's certainly a tool that can be used and can be helpful in some cases, but I don't know enough about yours to know And while I think maybe what we can say is, I think this is useful for people because we talk about necks quite a bit, right? So if we're thinking about this postural component for people, there are a lot of ways to understand that. The way that we're talking about in this particular question is we're saying, hey, when I look at just like a static position, whether that's on an x-ray, whether that's kind of putting you up with a grid and just kind of looking at how you stand, that's one way to understand what your body thinks normal should be. Ideally, a super healthy brain allows people to just sit up tall, sit up normal, everything's straight and narrow, and then lined up, which allows us to be able to move appropriately, to be able to take in information appropriately. And when we get these deviations in the spine, we're moving around. I can see my camera's crooked today. That's pretty cool. Straighten me, see myself out here. Make myself look crooked. Nope. It's even worse. This way. That's what happens when you do it in the mirror. Okay, so here we go. So anyway, so if we look at the verticality, right, that is a signal that something's going on in the brain, whether that's from an injury, right? You got injured in the joint, and the joint has some pain in it, and then we stop moving it, and then the next thing you know, that's the way your brain learns how to move. It's like a limp. That's one way we can look at it from a static positioning, and then we say, hey, what types of things could we do so the brain would understand how to move this better and then regain kind of a more normal position, a more normal function, right? So that's kind of like the broad question you're trying to ask and answer. And then for some people, having manipulation, chiropractic adjustment may be part of that, maybe something different. I don't know. It depends on what causes it to be in that position in the first place. Cool? But the way to think about it is not as though like your spine one day just like kinked itself over and then all you gotta do is kink it back and life is happy. It can be an input, but it may be good, it may not. We don't know. The other way to look at it is jumping from static to dynamic. So we say, oh, we look at how you sit or how you stand, and that's a certain way, but then we also want to understand how you move. So you may have this really good posture when someone sets you up on an x-ray, but then you go to move your head, and when you try to turn your head turn looks more like this, right? Or we say like, this feels normal, or when I tip my head back, oh, it's super stiff, or I have to like, pick my head up when I go back. So there's all these other components of movement that matter. Or when I move my head, do my eyes get blurry? Or does one go up and down? Or does one get dark? Or all sorts of things, right? Do I get dizzy? Do I feel pain? So a good place to start is to think about what do things look like just statically? How does that influence how a person works? And then we say, when we take them through dynamic movements and then we start to integrate other systems into that, does it change what we're seeing? And if it does, then that might be an indicator of maybe an adjustment is the tool, or maybe something else is the tool, and we can get into those things as well. So hopefully that helps. All right. Wildfire, Nicholas, good to see you. I think it was Canada Day a couple days ago. Congratulations. Hope it was great. All right. Wildfire asks, do compression socks work, and what kind do you recommend if yes? So the question would be, what do they work for? I'm assuming that you mean working in something like POTS. And there's different ways to think about that. So when you say work, does it give you some relief in the moment, right? So that could be true. Some people will find that just having the compression, even if it has nothing to do with the blood flow, even just having the compression, giving sensory activity to the legs can be helpful, which is great. But then what is the problem we're trying to solve with compression socks? And is that problem best solved with compression, or is it best solved using a different tool? I don't know the answer to that in your case. I typically do not use compression socks as a primary recommendation. Most people that come to see me have already had some experience using them and kind of know how that works for them, but we're also trying to get them to a place where they don't necessarily need them. Compression is just a way to compensate for toothpaste tubing some blood back up your legs and being able to get more opportunity to circulate it in your heart. Whether that happens or not is a little bit unknown, that's still kind of up in the air. We know that if you put people in compression all the way up to their chest, hey, that's great. They do really well, but they also look really weird and it's hard to move and it's hard to get on. I remember I had one case where she had come in from Europe, let's call it Europe, and she had come in and they gave her compression stockings and they were like, you have to wear the compression stockings, but you need to wear them thigh high because lower than that it's not going to work. So she was young, she was probably 15 at the time, and she would try to put these compression stockings on, but when she would try to pull them on and they were so tight, when she would do that Valsalva to pull them on, she would pass out. So she'd be in the morning getting ready to go to school, and she would be putting her socks on and passing out, and then waking up, and then trying to put her socks on and passing out. And this was like an every morning experience for her. So the moral of the story there is, it's not to say compression stocking is bad. That's not what I'm trying to get across to anybody. Don't go throw them away. Do what you want. But what I am saying is, for her, what might have been more useful would actually be understanding what life looks like putting them on. Because when you do that Valsalva maneuver, you create that pressure in your chest, and we see that causes people to pass out. We have a whole different way to start to solve that problem, and that's what we were able to leverage. So we took that information and stole it, and we used it to work on baroreceptor activation, and actually use this really cool cerebellar integration. So she's also hypotonic, so really floppy. So we used stimulation through the cerebellar Purkinje system to be able to increase outputs and help integration at the NTS, which helped baroreception, which made it so she didn't pass out putting socks on, but also was able to stand up, move around, go back to school, like all that fun stuff too. So that's pretty sweet. So for what that's worth, that's a long story about compression socks, but just to summarize it again, I think that compression socks can teach you a story about something else that is maybe more juicy, more useful to attack, but it can be really good in the short term when you don't know what you're chasing and you don't know what to solve, and you need a little help, you need a little boost to try to get some fuel back in there. For a lot of people, actually, it's not so much the compression of the fluid, although that does matter. If you notice like you're not swelling, then that may not be the thing for you, but what it can be for some people is a stimulus. So that compression stimulates your skin, your muscles, your joints underneath that tissue that help you feel a little bit better, helps you feel your body a little bit. And for a lot of people that we see, that's actually the underlying problem, and why compression stockings can be useful, not just because they squish your legs. All right, Doru, how do we access your clinic? You can give us a call. You can check out the website. Usually, through that process, you'll speak with Dr. Claire Keiser, and she'll kind of get a lay of the land to see what's been going on with you, what's brought you to this point, and then we kind of see if we are potentially going to be useful for you or not. So there's a little bit of a process there to make sure that we're going to even have a shot at doing a good job before we take people on. So that's kind of how that process goes. Lots of ways to find us. You can just, Keiser Clinic on the website, or I'm sure there's a link in YouTube or Facebook that you could hit up. All right, Ferzak, interesting question here. It's summertime in the hot part of the world. Are people with dysautonomia more likely to have a heat stroke? Interesting question. And one that comes up, it's a little bit hot here too, and what people will notice is that heat sensitivity is super high with people that have dysautonomia. And are they more likely to have heat stroke? Would be basically your body starting to have some relative shutdowns to heat, to being core temperature goes too high. So if you are a particular person that has dysautonomia that has thermoregulatory issues, then you may notice that. I have a couple thoughts on it. Number one, it makes me think of, so I used to practice down in Atlanta, and for those of you that are familiar with U.S. geography, it is south of Michigan, but it's hot Atlanta, the nickname, right? So if we used to find that a lot of people would come to Atlanta from northern places, it was really hot, and being able to try to deal with that with dysautonomia was its own interesting beast. And one of the things we learned very early was that the people that had actually a harder time sweating tended to have a harder time with the heat in terms of being able to tolerate it for longer terms in that much hotter environment. So I thought that was very interesting. And when we kind of back that up, they were the ones that had the hardest time being able to regulate their temperature. So being able to be exposed to temperatures kind of like outside of that normal sweet spot around 70 degrees, and the deviations from that would be problematic. Now, deviations toward the cold tend not to be as bad because it pulls the blood out of the extremities, pulls it in toward the heart, makes it easier to be able to contribute to the brain. But anything that goes on the other side of the scale where you're going warm, that warm is going to actually push more blood out into the muscle and into the skin especially, which takes it out of circulation. We talk about that a lot. And if you're having a hard time being able to sweat, that's a really good indicator that your body is already having a hard time being able to control or be able to recognize temperature changes, with the caveat that you're not having a neuropathy that prevents the sweating, right? So also people that can sweat though, we notice that if they could sweat, we could adapt them toward heat at a faster rate, although it still takes effort and you still find that people will overheat and you got to cool them down really fast. And you kind of let them get warm, you got to cool them down really fast. So the quick and dirty is to have a way to be able to cool that core temperature down and be able to oscillate into the heat and then cool it down, and then into the heat and then cool it down, and let your brain start to get a calibration of the difference between like 70 degrees and 80 degrees. So you can start to move between those two. So in terms of heat stroke, yeah, if you can't thermoregulate as well, then you're not going to be able to manage core temperature as well, which means you are more likely to have heat-related problems. And I've got segue right over here. I've got this little pile of kiddos that wants to say goodnight. So I'm going to give some hugs, say goodnight to everybody, even though it's super bright outside still. You guys say hello to the squad.
Hello.
All right, team. Oh, we got an airplane and everything. I love you guys.
Hi, Dad.
All right. You guys have fun?
Come on, Daddy.
Oh, we got emojis coming out. All right. How did you even do that? All right, so I got a big emoji thing in the middle of my screen now. That was good. That was good. All right. We'll see you guys in a little bit. Okay, I'll come check you in a little bit.
Okay.
All right, love you. It means it must. Oh, it's not too bad. It's only 8:30. All right. So summertime, late bedtime around here. I'm having a hard time closing the door. Hold on one second. I got you. Okay, good question, Fairzuck. Thanks for letting me say goodnight. All right. Let's see. All right. Howdy, Doc. Saw your video on bloating. Very informative. What about bloat that stays for a few months, goes away, and then comes back? No clue what's invited or sends it away. Could it be lymph? That's an interesting question. So, the way we think about bloating to start with, because there's a lot of things that can cause bloating, right? And the video we posted was kind of highlighting the difference between like an abdominal mass, where someone's just like has a tumor that makes you look bloated, but it can just continues and it sticks around and stays, right? So that seeks out one type of care. We also know that like bloating right after you eat and seeing that big expansion, like you got like, you know, you look pregnant, but then it goes away and then it comes back when you eat and then it goes away. That's different. And we highlighted kind of two common features for why that can occur. Number one is the one that you hear most commonly is when we think about SIBO, or small intestinal bacterial overgrowth, where you've just got the wrong stuff growing in your gut. And when that happens and the metabolism starts kicking up from kind of the bacteria that we don't want to live there, we call them bad bacteria, but they're just opportunistic bacteria. They're taking advantage of a different soil type and they're moving in. They yield different off gases that can cause that bloating activity. Sometimes they can cause inflammatory loads, and you see that response that ultimately gets worked back through the body. Another one that can happen that is less common or less maybe understood is we'll see the bloating happens as a fluid accumulation, where we get like an instantaneous sort of like drop in fluid. People will also characterize them along with histamine responses, like an allergy, where you'll see fluid accumulate in the gut really fast. But what's interesting is you can cause them not just from eating. I've seen them be caused from just like we can instigate them with the way people move their eyes, like when people look up and down and then see that expansion of the abdomen, or have people turn their head a certain way and you see the expansion of the abdomen. And these are very interesting cases, but they don't resolve with diet. So it's really worthwhile to pay attention to what is that causality underneath it, and recognize the primary versus the secondary symptom. Now we're asking about sticking around for a couple months at a time, which is interesting, especially if you're a lady and you might think about like the cyclical nature of your period, and you say like, no, maybe it kind of comes in more of a monthly cycle, but here we're saying comes and goes a few months at a time. So that one's kind of interesting, would take a little bit of diving in, because the cyclicality of a couple months doesn't really correlate with a whole lot of natural cycles that we have in terms of human bodies. So then we would say, like, is there an exposure to something, or is there a flare that happens with something, or do we see changes in lifestyles, changes in medication, changes in physical activity, changes in stress or emotional activity? So now you start going down the road and trying to figure out all of them. There's nothing that jumps out to me in like a moment that says like, oh, a couple months worth of bloating at a time could be this. Could it be the lymph? It could be, if you're getting sick and you're noticing that's the frequency with which it's happening. But you're going to have to find a catalyst if it's happening a couple months at a time, and if it's happening and then going away. So that would be like the starting place for that. Is like we need to figure out what is the thing that kicks this off every couple months, or do we need to learn more about it? So thanks for letting me talk about that. Okay, we got some fashion tips being exchanged about compression stockings. Sarah Renberg asks, could you please talk about measuring breakdowns in neurovascular coupling and how to think about rehab modalities to improve those measures? Very cool. So let's first define neurovascular coupling. So neurovascular coupling is a concept that we apply to the idea that when you fire a neuron anywhere in your brain, and usually there's a constellation of them happening at one time, the firing of the neuron initiates a response where I'm going to draw blood flow, fuel, oxygen, glucose, toward that working tissue to allow it to keep kind of funding its work. So if that's true, then what we're saying is there needs to be this fusion that happens between the nerve or the neuron and its blood supply, which is pretty cool. And one of the ways this is done is through glial cells in their end feet, in the way that they attach to a neuron, and that allows them to, as that neuron is working, it allows a signal to drive back through the glial cells and then go to the vasculature, dilates the local vasculature to that area, and then keeps the blood supply rocking and rolling, right? So one thing that happens that's really interesting is when you injure brain tissue, then you affect neurovascular coupling. That's kind of wild. Obviously, none of us was there when it was created, so we don't really know how it was created, but the idea is that when you injure tissue, the process of healing the tissue involves a lot of inflammatory mediators coming in. So we hear the word inflammation, we want to kind of break the habit of thinking about that as bad, and we want to think about that as healing, right? The question is it something that heal over a short time or over a long time? Is it too long? Okay, that aside. So if we think about healing as the mechanism, we've got all these inflammatory mediators come in, and what we see is that neuron becomes less active as it's healing, and then it also kind of like, you can picture like a coupling for a spaceship, and you can see that it kind of decouples from that end feet. The end foot kind of like pulls away, and that prevents us from over perfusing the area and causing further injury, we think. It seems to be. And because of that, though, as that neuron gets a little bit healthier again, sometimes we don't see the proper coupling occur. So when we try to use that cell at a higher rate, at a more normal rate, so let's say it's just for the purposes of illustration, let's say these are cells that are in charge of math, right? and you notice that when you have a head injury, and all of a sudden, like anything thinking is like gives you a headache, my head's pounding, I can't think, I'm really sensitive. And then like math is like, whoa, I don't know what's going on. But then as you get a little stronger, things start to normalize, but you find out like, I'm still like a little bit slow. This can happen where those neurons, when we're trying to just like jump back up to gain level, they don't respond as well. And part of that can be because the metabolic component of how we're coupling that neuron to its fuel source may not be working as it previously did. So in order to heal a neuron or to stimulate it, in order to heal a neuron, it actually requires stimulation. If I don't stimulate it, then it doesn't get any stronger, therefore it doesn't heal, so to speak. So if that's the case, in order to heal the neuron, as you stimulate it, that is then what closes that loop to be able to create the coupling, which is pretty cool. That's the way it should be, if you got to draw it up. So the issue though becomes like, to what degree should you stimulate it? This is the nuance part, because you might say like, go for it. But then you remember that not all stimulation is the same. And I had a colleague tell me gave me like a really good metaphor for this that I think is really useful. He's talking about in the World War where Russian and American soldiers coming into concentration camps, I know that's morbid, but stick with me, were finding people that had been just starving, like eating, like boiling their shoes to make the soup, right? To like dissolve the glue, like profound starving. And these soldiers were so compassionate. So they would take out their MREs, which is like a super condensed, processed calorie meal, and would start trying to feed these starving people. But what they were finding was the food that they were trying to give them, their body couldn't tolerate. It wasn't strong enough, and as a consequence, some of the people actually died eating the food even though they were starving, which is just this wild idea. But if you take that and you think about it in terms of brain rehab, then you can kind of start to see it where the dose or the amount has to be enough so that we don't kind of overstimulate the neuron to the point where we injure it. But we also have to give it enough stimulation till we get all the machinery to work again. So there is a sweet spot. And you can look at that by kind of judging. Part of what Sarah asks is how well that neurovascular coupling is able to start to kick on, how much strength that neuron is starting to gain over time. And it may be that you have to feed that neuron just like a little bone broth at a time, let it start to get the machinery of its digestion working again, and then get going. Anybody who's ever done a fast, we had a good friend and patient do this a couple weeks ago where they did a 3-day fast. And most fasts, if you start going over that period of time, you don't like break the fast by having a steak, right? That doesn't feel good. It's overwhelming. Some people throw up, stomach pain, right? You start off with like a little sip of bone broth, maybe a smoothie, just really light meals until you can start to eat again. And you want to think about treating your neurons the same way. So if we've injured them, we have to start really slow, but we can let them build over time and trust that that process can work. And that's where this neurovascular coupling side comes in. One of the unique ways that you can look at it, some people will use fMRI as a way to kind of get a broad sense, like having you do some different cognitive tasking in an MRI machine, and you can see if you're able to visually see bold imaging, and that can be a useful strategy. We do things a little bit differently. We're looking at a little more dynamic. I want to understand how people move and how they think. So I look at those things on an ongoing basis where you look at, can someone sustain an activity or they become fatigable and they get tired as they're doing it. So simple example might be like tapping your fingers. If I have you tap your fingers and you start off like a beast, but then all of a sudden you start to kind of break down, then I know that's fatigable. I know that system of neurons, as you start to work them, they may not be able to sustain that activity the way we would normally think of them, and we know that that metabolic activity is going to be compromised. So when you go back to the original question and like how do you do different types of rehab to be able to improve those measures, the sky's kind of the limit. What you're going to try to think about is which areas are affected. That's the number one. Which of these neurons or networks of neurons are struggling? And then the question you ask of that is, what kind of receptors are going to talk to that pathway? and then how can I stimulate those receptors? So that might be receptors that are involved in your vision. They might be responsible for the way you move your body, like your arm, one leg, arm, other leg. Might be related to the way you move your head or the way you jump your eyes in this direction. So you can start to get into real nuance because all of these different pathways are responsible for different things. And if you can understand the ones that don't work very well by looking at what they would respond to, then you know how to stimulate them. You just have to bring the dose down to what they can tolerate. So the playbook opens way up, which is why it's really useful to have a big toolbox of things that you can use to stimulate a body, because then it allows you to be able to stimulate it in lots of different ways depending on what's wrong with a particular person. Hopefully that helps. Okay. Susan asked a good question about the keto diet. April 25 publication on the keto diet, improving cerebral blood flow. I did read that one. And also it's worth diving into some other ones because it's not the only one. It depends on kind of your starting place, on where you were in diet prior to that. What was the metabolic health of the person? Where was your base? So do you come from eating, like a very fast food heavy diet, a very high processed food diet, and then by switching to a primary protein fat diet, does that offload some of that, some of the strain on your blood sugar system, so on your pancreas and your liver, and being able to control blood sugar, right? So it gives you a more stable way to do that. For some people, it also helps just to be able to maintain lower level of GI inflammation, or we see that if we're having difficulties with oscillatory blood flow in the gut, then we can translate that to the brain. So I think the useful way to think about that is not that keto is the answer for everyone. I don't know that it is. I don't know that any diet is the silver bullet, but I do think that being able to understand where you are metabolically, like what kind of health you are in, to what degree that is causing problems in your brain, or is your brain causing problems in your gut, and using that as a mechanism to be able to say, like, what foods would serve me best to be able to help out with this. Because you can improve cerebral blood flow with lots of things, but in terms of what we're going to look at with people that have autonomic types of symptoms, if the keto diet is helping, number one, that's not really what this is. This is in healthy norms, and this is mostly a blood sugar paper. This is about stabilizing blood glucose and using that as a way to augment peripheral arterial function. So these are people that just have like poor endothelial function in the periphery. So as you improve that, you improve baroreceptor tone, you improve contractility of the heart, the overall system gets better. Exercise does similar things. There's like a load of things that you can look at. So first question is like, what brought you there? And then you figure out, well, how do I work backwards from what brought me there to solve that problem? Can keto diet be really helpful? For some people it can, especially if we're starting from a place where diet hasn't been a priority and we're trying to get some rules around eating that become helpful. And I think that in most cases, we're very lucky that that's what most of our problems are, is that it's not a function of not having enough food anymore, which is kind of wild. It's amazing. But then we have to manage that, we've got to set some rules and boundaries for ourselves around eating so that it doesn't swing us into problems on the other side where our body's trying to deal with either the type of calorie that comes in or what comes piggybacked in on top of the calorie. So I think that's a really good question. It's really insightful. And I'm definitely not dodging it, but I think, again, right tool for right problem. If blood glucose is a big problem for you, not specific medical advice, get that checked out, and you may find switching to something that gives you a little more stability in the blood sugar throughout the day may be really useful for you, if that's the heart of the problem. Okay. I'm going to give just a little bit of a comment on some of the compression garments. Make sure you guys are careful about not causing, so sometimes if we're talking about wearing like shorts, make sure that we're not creating a restriction where we're having a hard time getting venous flow back up to the heart. We're talking about a plane ride here. If we create a scenario where there's stasis in the legs, we don't want to get into like a deep vein thrombosis or a clot type of a problem where we're not able to actually circulate through that venous tissue enough. So if you think about, like, if you draw, I don't have a drawing thing today, sorry, but if I have shorts on that are tight, but I have a gap between, like, maybe I got like knee-high compression and then I got a gap between the shorts, I can create a problem where I have circulation up to a point and then I slow it down, which is going to cause an accumulation of fluid, which may slow down some of the flow in that area, and we don't want to risk having a blood clot. So just something to think about, especially if you're going up on a plane, you're going to be sitting for a long period of time. I know you're just looking at ways to try to get a little bit of relief, but just something to throw into the calculus so we don't end up with a worse problem than we started in. Okay, a question from IH. Can POTS cause tingling in your feet, hands, and scalp? So POTS itself, maybe not, but if we have hypoperfusion or small fiber neuropathy, these things happen a lot. So there's like an amalgam of patients in my mind that have shared this complaint. And the two main things that I think of are when they are in the midst of hypoperfusion, so they've been up for a while, and then their breathing starts to get not great, and they start to feel dizzy and lightheaded, and that's usually when the tinglies start to come for a lot of people. And especially if the breathing starts to get shallow or fast, then you'll notice it even faster. The second thing so it's not really the POTS that's causing it. It's a nomenclature thing. It's the change in blood flow in the brain. That can be from orthostatic problems. It can be from a migraine. So if we have a hemiplegic migraine where a portion of your brain is affected, you may notice that only on one half of my body do I feel numb, or do I feel heavy, or do I feel weak. And that can be included in the scalp. The other thing to consider, so we've got cerebral hypoperfusion, changes in breathing, those things can kind of work together. And then the third part would be if we're having a small fiber neuropathy. The one caveat will be you will not tend to have it so much in the scalp as you will in the feet and then the hands. But again, that can happen for different reasons, but it's something to think about if that is the nerves themselves, where we cause a little bit of nerve irritation or inflammation, that can cause the tingling as well. Cool. And then I guess if you want to throw another one with that, you could put like nerve compression syndromes, but that won't affect all those things at one time. Usually if it's in your head, your hands, and your feet, it's something that is a metabolic cause. The fastest way to get there is hyperventilating. So hyperpnea or tachypnea. Okay. Megan Bradford. Good question here. Is measuring CO2 via blood work versus how you monitor in the clinic, can they correlate? And they can, which is really good. There is an extra step involved when we're looking at CO2 in blood work, and we don't get to see it dynamically. So you can't really do blood draws and look at the difference between laying down and standing up, or when you turn your head. You just kind of get a baseline value. But that CO2, when you measure it in your blood work as a baseline value, can be helpful for understanding if the pH is off in the system, looking at the blood gases. So what we use in terms of what's called end-tidal carbon dioxide, when we look at that, we're using it as a proxy for what's happening in the blood, but in a way that we can do it constantly in a breath-by-breath basis. And then also, obviously, you don't have to do a blood draw every time. So it allows you to get a more dynamic or ongoing view of what's happening in that system and seeing if things are changing it. So it's interesting if you've got someone that, let's say, that CO2 level is low, but we'd like to know the difference between if it's a problem sitting down versus standing up. That matters, right? Or can we correlate it to looking at the partial pressure of oxygen in the blood, looking at sodium chloride, chloride, and being able to understand, like, what does that whole picture look like? So then you're looking at that electrolytic balance. But two ways of looking at the same thing, just you're going to get a little bit different information from them. All right, so we're really chatting about shorts. Love it. Amanda said, the case studies in your previous live stream really helped with discussing deeper to learn. It helps you not have to be general without any problems with online or patients. I really liked it. Yeah, I like doing the case studies. We actually got a couple lined up that we're going to do. I'm really excited for them. I always end up torn because I get to see really cool stuff in the office and I want to share it really badly, but then it's also not my story to share. So, and then obviously a lot of people are like, get people on to tell their testimonials. I understand the value of that because I like it. I would like it too. When I think about my own health, if I'm working through something, I want to see somebody that's just like me, that had the thing I had, and then was able to figure out how to get through it, and then I can look at them later and they're doing great. Like that is the perfect scenario, right? But also for patients, there's like a superstition I have around, I don't want people to have to like commit to saying how they're doing out loud, because then on any given bad day that we all have, if someone asks us like, how you doing today? Like, I don't want them to have to feel torn about that, like, because we're talking about like, how are you feeling overall? So I have this weird, I don't know, not a problem, but like hesitancy about sharing that. And then also, I don't want people to have to I don't want people to feel like they should have to do that. I want them to just like get better and then go live their lives and then like kind of forget this ever happened in some ways. So because that's what I want so bad, I have a hard time asking for testimonials. And that's a long-winded way to say it makes me feel more comfortable to anonymously talk about cases so that we can talk about what's the mechanism, what did we see, what did we find, what did we do, and then look at the outcome. I know that washes out a lot of the emotion, but it also makes it so that we're talking very clinically without having to like put anybody else's future on the line. So anyway, we'll keep doing a lot of those cases. I'm always open to trying to figure out how to share them better because they're just awesome. But I'm also like strangely hesitant to try to tell other people's stories or have them tell their stories. Dr. Ginny is going to give me a hard time about that. All right. Okay, so next question we have here. Oh, hold on. I'm trying to make sure Okay. What does it mean if someone feels skin sensations like bugs crawling or loose hair, sometimes like a TENS unit, but without it and in random places? Any recommendations? No recommendations via chat, but this is called dysesthesia, where you're just feeling things that aren't there or shouldn't be there. And sometimes they can be just things that happen. They can also be things that, like, if your awareness is super high, then you might notice things aren't there. It's like if you say like, am I itchy right now? Then you'll find a place where you're itchy, and if you try not to itch it, you'll think about it more, right? So kind of like that. But also you can have dysesthesia from problems in parietal lobe, where you're processing information from your skin and body. That can be number one, especially if you have like a patchy sort of hypoxia or axonal injury there. That can happen. It can also happen if you have problems in the peripheral nerves, if we're getting the onsets of little neuropathic findings as well. Recommendations, you can't have any because we don't know what's causing them, but we can give it a name. The symptom's called dysesthesia, and they can happen with different longitudinal levels of lesions throughout the neuraxis, and then you just got to figure out why. All right. SD said compression garments help with the stability and proprioception. I think that's actually a lot of what people experience, is that it's not necessarily helping the blood flow so much, but these are people that actually don't feel their body very well, which is why the blood doesn't distribute very well. And if you squeeze them hard, they can feel it better, and then it helps their brain know where they are. So I think like the reason that compression garments are given and the actual thing they do for a lot of people are very different things. And then Veronica says, yeah, but they're stinking hot, and they are, especially in the summertime. So I would love to see people not have to use them. Corey, what's happening, man? He says, curious, does CSF stagnation in the head or neck damage the dura? Also curious about the vasculature of the head and neck is damaged by congestion, specifically in the dural venous sinuses. So damaged is an interesting term. It depends on why they're stagnating. So CSF is cerebrospinal fluid. So if we're noticing that people are having a harder time draining that out, does the accumulation of it matter? Now, it will always be in there, and the CSF does have some degree of, like, it's carrying different things around, different proteins, different substances. Some of them, like, you don't really want lingering really long time in the system, but damage, maybe not. Maybe the better way to think about it is if we start to get stagnation in the system, the endothelial walls don't have as much shear, which, like, they don't have as much pulsatility. And that pulsatility is what stimulates that artery to be able to, it produces different types of chemistry. It allows it to work the muscle. And because of that, if we don't have that, we see endothelial damage being almost like an atrophy, where it just doesn't work as hard. It gets a little sloppy. It doesn't release the normal chemistry that it would, which lets the walls get a little gunked up. And then we start to get problems with things sticking to the walls. So platelet aggregation, but it doesn't even have to be platelets, like we talked about a couple weeks ago, where we see, like, clots and stuff starts to form on the walls. So ideally, you want to think about it like a hose. You don't want water sitting in it. You want to keep it moving. And it's actually the movement a lot of times in and of itself that can maintain the health, rather than let it kind of drift toward atrophy. So in terms of damaging it, I wouldn't think about it as though, like, it's like melting it. I would think about it as it's getting, like, kind of lazy and weak. Would be kind of the way that I would look at it. Specifically in the dural venous sinuses, that dura is super tough, and it's got not as much capillarization as you might think about, but it does help with kind of some of the waste removal in the system with the lymph. So ideally, you want to keep it moving, keep it not accumulating, so that you're able to exercise that system. Exercise is probably the wrong word, but it gives you a better sense of it in your mind. Cool. All right. Lucila says, thanks everyone. Thanks for answering the question last time. Appreciate it. I'm just going to say again, I am interested in kind of like going a little bit slower, even though I really desperately want to answer everybody's questions. Sometimes at the end, I feel like I have just raced through all the questions without making sure that I am speaking about them in a way that is maximally useful. Yeah, Veronica says, back to her hot compression socks. That's the side topic for today. I can't use any compression during most of the year because living in Arizona. Yeah, they're super hot. But they can teach us about proprioception, which can be useful, and then you can find a way to maybe get rid of them. Jesse Miller, can quitting a substance that affects neurotransmitters cause temporary POTS while they're trying to balance out? Is that normal? I like that you said, you didn't say me specifically. Thank you very much, Jesse. So, as a generality, this happens with a lot of things. So it doesn't really matter. In a lot of ways, the substance isn't always the most important part. It's that you're changing the neurotransmitters. It needs time. You can see this from everything from caffeine and nicotine to SSRIs, right? So when you're changing fundamental chemistry in the brain that's used everywhere, and the fancy word for being used everywhere is it's ubiquitous. Most of these neurotransmitters are. You have to think about it. When people casually talk about neurotransmitters and they say like, oh, it activates my dopamine, or it stimulates my acetylcholine, or my serotonin gets high. Those neurotransmitters are being used constantly throughout the system in different ways. So it's like a very blunt way to think about it. But this question here is a really good one, because especially in the three that I just mentioned, and other ones as well. When you upset that neurotransmitter balance, one of the things that may happen is we see that tachycardia as a response. You think of it almost like a withdrawal response, where people think about withdrawal from anything. You're more likely to kind of get sweaty. You're more likely to have palpitations, big heartbeats, fast heartbeats, headaches, feeling lightheaded or dizzy. Like those can be signs and symptoms of withdrawals as well. And withdrawals are another way to say coming off of a medication or a substance of any kind. So, do that with your doctor's help, with supervision. Make sure they're kind of keeping an eye on you. But in a lot of cases, I feel like I generally trend toward the side of people that are trying to get off a substance, generally speaking. So I'm rooting for you, and I hope it is a temporary deal, and you can work your way through it and get to the other side feeling better than you were before. But it can be part of that for sure. So hope that helps. All right, Eileen Hart says, I've been in the pool 3 times a week, very jealous, slowly exposing to sun, but I notice if I get too much, I get a little mast cell rash. Yep. Beautiful example of dosing, right? I love it. It can be really easy for it to sneak up on you and get a little long, especially when you start getting comfortable. You're like, oh, I used to do this for hours. Oh, feels good. And then you're like, oh shoot, I can't go too long. So it is helpful to know, like, where's my threshold? Maybe it's for a lot of you that are really pale and have been indoors for a long time, are very sensitive. You may only get a couple minutes in at a time, but that's okay. Start somewhere, know kind of where your thresholds are, know what you can do to cool off. Eileen knows, she gets in the pool, helps her stay cool. She still gets a little sunshine, and she's able to start building. What I want to see is what this looks like next year, and that will be super, super cool. So just keep after it, but stay low and slow. Enjoy the sun, enjoy the pool. Hopefully the bodyguard hangs out with you. Patrick Bro says, grateful for the info. Thank you very much. Thanks for saying that. Really hits home about what you mentioned about the diastolic increasing when standing on the post today. Gave me much hope even with the pooling. Can you elaborate at all? Okay. So I'm not sure. I talk about a lot of things in posts, so I don't know for sure. But diastolic increasing when standing. I don't remember the context of this particular one because I do a lot of them. Sorry about that. But with the pooling, let's talk about the diastolic blood flow in terms of POTS. Why do we look at it? So let's define systolic and diastolic first. So when you get a blood pressure number, they give you the top number and the bottom number, like 120/80 is that's our current ideal. Sweet. Top number is systolic, bottom number is diastolic. Why do we have that? Well, it's because as blood is pumping through your body, it's doing it in waves. So every time your heart beats, it pushes pressure into that artery, right? So it pushes more blood out of the heart into circulation, which is going to amplify the amount of blood in the system. But then in between heartbeats, it kind of comes down a little bit. So that's what you're looking at. The systolic part is when that expansion happens, and then the relaxation part is the diastolic part. So that range is where your blood pressure waves back and forth with every heartbeat. Okay? So when we talk about pooling, some of the ways we start to differentiate that are if we're having problems with being able to generate return back to the heart, a huge indicator is going to be, we want to look at, are we able to let the brain talk to all these peripheral nerves to be able to control the contractility of the heart? So when you stand up, all of the vessels in your body should get like a little tighter, because if they don't get a little bit tighter, all that blood's going to try to rush down. So to prevent them from rushing down, we just get a little bit tighter, and that allows us to be able to push the blood with a little more velocity. That lets us return it back to our heart, number one, make the loop from heart through the legs back up. But then it also makes sure that the blood that we're pushing up has enough tension to be able to push it into your head. So as a general state of being, most people will notice that as they go from lying down to standing up, there's a little bit of a bump up in the diastolic pressure. So all of the arteries in the whole body are going to be just a little bit tighter. So it's going to have a little less relaxation in the downstroke of the heartbeat. What that means, though, is that if you have that elevation of the diastolic pressure, it means that your body is able to create the constriction in the vessels, which is awesome when we think about blood pooling. Because if I can't create that constriction in the vessels, I am going to just fall to gravity, right? So that blood is just going to drift toward gravity. And you might be thinking, well, the return really happens in the vein, right? So the arteries are pushing it down, and it goes into the capillaries and the arterioles and capillaries, and then into the venules and veins, and then it heads back up. But it relies on the pressure from the arterial system to keep that blood flow moving and coming on up so that we can return it back to the heart. So if we have pooling, we want to differentiate it. Is it an interstitial type pooling where we're seeing like redness that happens in the skin, or it's reticulated, versus like more purple or more cold? And that helps us to determine like where in that system the pooling is happening. But if we've got the diastolic pressure is able to maintain its rigidity, then that's great, because we know all those nerves, there's a high probability that we're not dealing with a neuropathy. It's not that we can't activate that system. It means that the control system up top here isn't quite managing it perfectly, which is great, because that gives us an inroad to be able to figure out, well, why isn't it managing it perfectly? And let's fix that. And if we fix that, can we get that sucker to start pumping back through at a better rate so that we're not pooling, we're not creating mapping issues in the body? These are our compression folks, right? So where I'm not sending it real well to my body, and it may end up accumulating in my legs rather than being pushed back through the system. So yeah, so that's kind of, we did like a little segue there where we merged the two things. So being able to give a better representation of where our body is in space allows us to create the blood flow more efficiently, return it back to the heart more efficiently, and keep that system running. So there we go. Wildfire says, I can't sweat. I've got MS-related dysautonomia. I feel that. And the heat is a big problem, for sure. If you're having a hard time sweating, this is probably a comment from earlier. You got to be able to somehow dissipate that heat. Sometimes it means we got to figure out, some people, especially with MS, because it's patchy, will find that in some places I actually do sweat. So it'll be like in my one armpit, I actually sweat, or on my neck on the back, I actually sweat a little bit, or in my groin, or across my chest, or in my back, or there's like one spot that will still kind of get a little sweaty. And that can be tricky because as the heat rises, you've only got a couple areas to be able to dissipate the heat from, and then it builds your core temperature up. As just a way to, like a hack that people will use, not to fix it, but as a hack just to like get through the summer. I have seen people use like the cooling vests or the cooling towels that kind of supplant the role of sweating. So by like wetting your body and allowing it to evaporate, allowing your skin to cool that way, or even just dunking in the water and letting that water cool you down. That's actually what I do. I still, like here, I like to work out, I like to get in the heat, I like to be in the sun, I like to sweat, but then also I will use a cold bath or a cold plunge, and I will use that as a way to cool my core temperature down quickly so I can recover a little bit and then like kind of keep going and not get tired by the heat. So I feel that. You guys just have it like way more pronounced than I do. So kind of being gentle about how you approach it. So take the same strategies, but just pull them down on the dose level. Okay, I'm seeing we're getting to the point in the evening where my family came in, because we get the family comments. See, Bradford says, I see the royalty has arrived. Ain't that the truth? Veronica said, 5 kids. No, I have 3 kids, and we have 2 wonderful friends visiting us as well. So they were all out. Sounds and Sights Thursday nights in Chelsea. Wonderful little small town action. So they all went up there, watched the juggler, and then came home. Okay. All right. So back on the heat. We're in July. This feels like a heat time to talk. regarding the heat, if the goal is to cool off quickly, if you're overheating and then get cool really fast, would that not cause problem with robbing blood flow from your brain too fast? Good question. And so the way I talk about this one is we want to give your body the ability to start to experience it. As you're experiencing it, most of you will start to want to quit around when it starts to get too hot, overheated. So we've kind of already reached the point of saturation where your body's trying to figure it out. Ideally, you kind of hang in that a little bit, and then in hopes that we start to kick on the thermoregulators, the hypothalamus starts to crank out to the paraventricular nucleus, we start to do things to create sweating, we start to move blood into the peripheral tissue. And then the question is, like, how much are you already symptomatic and how much does that drag you down? Remembering that if the thermoregulatory system doesn't work real well, your core temperature is going to change pretty quickly. So you're just trying to push it up there, but then cool it back down. It's like the temperature on your skin isn't necessarily matched to your core temperature. So you're going to use something cooler to pull down that core temperature more quickly, just to prevent you from overheating and feeling symptomatic pretty quick. Now, however much you can tolerate being in it, be in it. And if you can tolerate being in it and just take like a cool shower or just like splash some water on your face, that's really great. Most of you will notice that being able to cool down quickly helps to keep your core temperature down. And remember, we're not trying to, here's where I'm going. The amount of cold on your skin is a stimulus, but it doesn't necessarily mean the temperature on your skin is going to be the temperature in the core right away. You're just using it as a way to artificially pull it back down so that you can get that exposure without then like falling apart after that. So you're getting the exposure, trying to kick the system on, and then cooling off and recovering. And you can keep oscillating through that. But if you try to sit in it too long, some people will become symptomatic and it won't do so well. I mean, you can cut that out, and a lot of people do, but it's not going to rob the blood flow from your brain. Because the cold is actually going to pull it in, circulate the flow. If you're submerging in water, you're going to get a hydrostatic pressure as well, where the water is going to push on your body like a big compression garment that you guys are talking about, and then it becomes like the world's best compression because it pushes all the blood up and it equalizes that. That's actually room temperature water that tends to do the best with that, but cooling it down can also cause a calming effect, because the anxiety starts to go a little higher with the heat as well. That's why a lot of people will use it even that feel really good and strong. But yeah, not robbing the blood flow so much when we get cold, more when we get hot, and then being able to reconcile it. Just see if you can go small. Heat, cool down. Heat, cool down. And just see if you can get more and more exposure to it. All right. Susan B, another good question. Does having vertebral artery dominance increase issues with cervical instability and chiropractic correction? Okay, so vertebral artery dominance, what I'm going to take that to mean is there's a unilateral dominance versus like rather than vertebrals versus carotids, we're looking at there's a dominance of one side to the other. There's a lot of that. There's a lot of just like hereditary anomalies that occur. We see all sorts of things on MRIs that you wouldn't expect to see just because you happen to be doing an MRI on someone. So in the relationship with cervical instability or chiropractic corrections, we obviously don't want to do things that create like a bone shearing force. So the thing that people worry about, let me back up, is the vertebral arteries travel right along the spine, so that when you're moving your head or getting a chiropractic adjustment, the concern is always going to be that you're going to injure one of the vertebral arteries. Now, it shouldn't happen that way unless we have some postural problems, some problems with the way the joint alignment occurs and the way they're moving. And also, it can happen with just different anatomical variants where it becomes more straining, but the risk isn't any higher than tipping your head back in the bowl at the hairdresser. Now, if you're unstable and you're finding that you're having these big excursions and they're creating tension against the vertebral arteries that you can measure, then you probably don't want to be, if we're saying your neck is unstable, it means that it is too mobile. If your neck is too mobile, then manipulating it and making it more mobile in that particular area is probably not useful. Now, if we want to increase mobility in a different area that is rigid to be able to distribute the motion across more segments rather than having it just, isolated in one segment and it's rigid everywhere else, that makes sense to me. But if you've got an unstable segment, it probably isn't going to make a lot of sense to manipulate that in a meaningful way unless it's unstable and it's, wildly subluxated, then there are some techniques, especially with upper cervical techniques, that can be a little more useful in normalizing that. But as a general rule, if it's unstable or it's unstable, don't adjust that area. You want to look for why is that area unstable? Is it from an accident or is it compensation? And can we distribute that movement into other areas? Can we create strength? Can we create control so that we're not deviating into those large excursions and ranges of motion? So that would be my question. Ooh, Megan, getting some shout outs for a good question on the heat. Do I need to revisit that? So if you're overheating and getting cold really fast, that's not going to rob blood flow from your brain. It's going to push blood out into the periphery and then it's going to pull it back in. So it's actually going to be really nice for your brain. Good question. So I'm glad because a lot of people were curious about that. Fairzucks, going to bed? Love it, man. Hope you're doing well. I want to know about how the trading's going too. Okay. All right. Danielle says most of us with bloating have gastroparesis as part of dysautonomic function. Yes and no. So that's a generalization, but yeah, gastroparesis can be part of it. Bloating can be secondary to that. And then also, if we're thinking about it on the kind of the multi-monthly basis, that's probably a different thing than gastroparesis. Endometriosis, yeah, so the video that we talked about had some pelvic tumors that were causing space-occupying lesions that made women look pregnant. Megan says, I'm just here to make you think harder. Love it. Nicholas, sometimes when I'm doing my exercises and I'm symptomatic, I lose sight of the bigger picture. For sure. We all do that. For sure. Could you re-explain how targeting these parts of your brain helps long-term? To think about that in a moment. I might have answered that in the neurocoupling question. That's okay. I do think that's a big part of it, though, because like the way I think about solving these problems, you're really asking people to take the long road, which is not always the easy road, and it is rarely the easy road. And when the road is not easy, it is also typically not as fun. So it's like work every day. It's like fitness. It's like eating healthy, all the other things. But the benefit is your brain is built to learn, which is amazing. If you can, we don't have much of a problem with that, thinking about it with other things. So if you're going to learn math is like an 18, well not 18, let's call it like a 14, 15 year project for most people, sometimes longer, right? So you start off in addition, or just like, what are numbers? All the way, some people are, people stop at different levels, but you're doing calculus, you're doing algebra, you're doing geometry, whatever. But it's a process that takes you all that time to learn. The bummer for a lot of the people that end up symptomatic is you have a brain that has been jostled in a way where it doesn't do one of the things it normally does and has to relearn how to do it. And you want to just do that as fast as possible because you know what it feels like to be healthy and normal. So the idea that to not be that for some people can be really stressful and it can be rough. But the same way you would think about, I know I can take a kid, and if we spend the time on it, we can get them to learn how to use their brain to make pictures in their head and to be able to manipulate those pictures in their head, and we call that math. Like, that is a very complex task. a lot of our folks are learning how to do very simple tasks. So sometimes it's hard to equate because you're like, oh, this should be so stinking easy, right? I play professional hockey. I get paid millions of dollars. People love me. I do interviews. I'm on TV. Girls think I'm great, right? But then I'm here looking at a wall and I'm having a hard time being able to keep my eyes on that letter without my head shaking. And then I notice that if I do that, it makes me dizzy, right? And you're thinking, I should be able to turn my head and keep it on the A. Why is that a problem? And then obviously that bleeds out into why you have the symptoms. So regardless of the tool or the exercise or what you're having to do to be able to solve your problem, all you're doing is just teaching your brain how to do a thing, and it's way easier than math. It just takes a little bit of like to be able to just say, like, can I do this now for me later? I don't have to do it for me now. Me now can be mad about it. Me now can not want to do it. Me now can want to be lazy. Me now can want to have a little pity party. Whatever the thing is. Or me now can want to go eat a candy bar instead. But I can do it for me later. And if you can do it for me later long enough, then you'll find that your brain is capable of learning these things because they're actually mostly uncomplex, and that's what your brain is built to do. So this is a conversation I have a lot because it's easy to, like, as you're working on these things, to feel like, can I keep doing this? Am I strong enough to do this? The answer is yes, you can. It just takes a little bit of work, but you got a great team. Number one, like, we are here. We know it's hard, but it's also very doable. You got great people that are, in broadcasts like this that just want to see everybody else do well, and I think that that's great. So if you're on a road that feels a little bit long, just keep going. We talked about this the other day. I had a patient in, and she was struggling on some CO2 exercises, just laying on your back, cycling, just could not get CO2 up and felt like garbage doing it. But then after a couple days, she's getting better, CO2's coming up, but it's still hard because she's deconditioned. Let's just call it what it is. And it's still hard, but we can see the numbers coming up. And actually now, not so much shortness of breath. We're starting to get through it. And we just kind of got to the saying of, like, if it's gonna suck, if you're gonna feel bad, you might as well get something out of it. And so if you're already symptomatic and you're already feeling bad, well, we might as well feel bad, but like be building towards something bigger. And I know that feels easy to say, right? But I've lived that too. I know exactly what it means. And if you're gonna do that, if you're gonna feel bad, let's try to make it mean something. Let's make it worthwhile. So Nicholas, I know Nicholas is super tough. So I believe in him, like, to the nth degree. So he'll do great, but we always need all of us need a little help and a little guidance along the way. I went through a time like that. My wife, God bless her, was like, am I gonna be able to do this? Yes, Nate, you'll be able to do this. And I just bug her about that constantly. So you can bug us about that too. Cool. All right. Craig asked the question. Prohan, I see your question here with thoughts on methylene blue, and should you use nitric oxide boosters alongside it? I don't know that you want to hear my opinion on that. I don't know that I would be for it, but I also wouldn't dissuade you from doing it. Yeah, I'm gonna reserve that one because I don't want to. Jury's still out on that one. Let's call it like that. Okay. Greg says, what testing would you recommend being completed before consulting with the clinic? That's a good question. What I would say is there was a couple weeks ago where we did kind of like, I don't remember the title. It was snappy though. It was good. It was about POTS. It was about diagnosing POTS. I think it was 4 steps. I would go watch that one because in that one, I go through what are the things to rule out. And that's the list. Is like, okay, can I go to my GP? Is there an anemia? Is there an infection? Is there anything here that's going on underneath this that's actually the thing that's going on that we can resolve? That is the thing. If you rule all that other stuff out, you can do that pretty quickly with some simple testing, and then that's where we become useful and intervention becomes useful. So I would go watch that and just look at, like, what are the criteria? Can you get just like your simple blood work? Do you need to get an MRI? Do you need to get any imaging done? And do you need to see if there's something worse going on that wouldn't be solved by trying to kind of solve the functional underlying part? I think that's a great question. Oh, Veronica's back to the compression socks. I'm unable to wear anything tight as I will end up getting hives and welts because of the MCAS and dermatographia. Yeah, that's the thing a lot of people experience is, again, so we're talking about the sensation in the system, right? So if people are hyposensitive, giving them more compression feels really good and they can feel their body better. On the other side of that coin are people that are way too sensitive. So if we do anything that increases the sensation, it's too much and their body has a negative response toward it. So now we have fully seen both sides of the equation. It is a helpful way to look at these. Are things hypersensitive, hyposensitive? Too much, too little? Are things hyperkinetic, or are they hypokinetic? Too much movement, too little movement? A lot of those things can get you a long ways if you just start breaking it down that way. Great contribution. Megan says, I'm a curious gal. What was the new piece of equipment you got today, sir? We are retiring our Formsby chair. It has lived a wonderful life. What we don't want to have happen is to have to service it while we have people in the building. So we got a newer version. We have it's a gyrostim, a tool that I've used a ton in the past. I would love to have another Formsby chair, but they only made one, and so there's not a big market for them. With the gyrostim is commercially available. It's a tool I've had a couple different times. So we're actually going to use that, and we're going to Frankenstein it with some of the things from the other machines. So it's going to be really cool. It's not done yet. If you saw the office, I got machinery everywhere. My boy loves it. He is just pulling bolts off everything, ripping wires out, having the best time. He said, we got done today, and he's like, Dad, hopefully we can get up early and work the whole day tomorrow. And I thought, that sounds amazing. So that's what we'll be doing. All right. That's an interesting one. So we got a little general ed here. Morblow says, I think that's Morblow, what health advice would you give a man in his early 20s who already exercises? So here you'd say, like, general health advice for most people. I'm not a sage in this, and there are a lot of people that give this advice or give advice in this field, like a lot of people that make a living doing that. But if you just asked me, I would say, if you already exercise, keep doing it, and keep doing it in a way where you're not fully just crushing yourself, breaking yourself down. I've done that. I love CrossFit, but also the way I was doing it was beat me up a little bit. So I took on this concept of, I want to work out to get old. So I want to be kind of like fit as long as I can. So I changed some things with that. Things that don't like make me hurt, but can also still make me sore and make me stronger, give me more endurance, all that stuff, flexible, all that. And then I would say you just kind of protect the inputs. Inputs are going to be what you put in your mouth, so food and water. The best quality stuff that you can afford. This is from where you're from. It's organic, doesn't have any pesticides, as clean as you can get it. Clean water, use a filter. If you got city water, try to use RO, something that just makes it so like you're not getting anything that shouldn't be in the water. And then your air, try to live in a place where you get good clean air or exposure to it and get outside. It's the simple things. Sun on your skin, have good social circles, not too many vices, not too much excess. And then people that care about you and you can care about, I think, and then knowing where you stand spiritually, and I think those are kind of like the broad general health things. If you got those things, you got a great life. So hopefully we get more people feeling healthy and strong again. All right. Austin G is asking a more, I think this is a follow-on question from what we were talking about in his early questions. He said, thank you. I think I remember you saying increasing blood flow and oxygen to the brain may be a first step further work. Would this make doing, say, vestibular exercises while supine or laying down more effective? It can. So if that is the crux of the problem you're trying to solve, is you want to do vestibular stimulation, but being upright doesn't work because they're hypoperfused, then starting by laying down, so then you're not fighting the perfusion, you can still get the vestibular stimulus. So using positioning can be a really great tool to kind of cheat and like let people have the mechanics or the physics of blood flow with gravity without having to necessarily manage them in the brain and then build the systems out from there. So that can be a great tool for sure. Okay, Baby's Bubby. I did gluten-free, carnivore, and keto for a long time and felt significantly better since my, I think there's a functional medicine doctor, told me to add carbs to the protein and fat at every meal and to have maple syrup. Great. Yeah, I think more rules around eating usually make it a little bit harder. People are wonderful because they can eat mixed meals. We can eat mixed foods. We have the ability to survive on a lot of things, which is super great. So yeah, that's kind of what I was getting at earlier, where trying to solve for the underlying problem is probably useful. Whatever rules you need to use around eating to make you feel better are a great tool. Sometimes, I wish I had my drawing ability today. I'm going to use hands. So there's this really useful tool. So if I think about how am I going to look to you guys? So if I start over here and I say like I am unhealthy, right? And I'm trying to shift my habits toward being healthy in the middle here, right? So the habits that I can use to shift to like, I'm going to lose some weight. I'm going to normalize my blood sugar. I'm going to get stronger. I'm going to sleep better. Like there are tools that you can use that can be restrictive that work really well to get to this point. But sometimes maintaining those habits of restriction or overgeneralizing rules can then start to actually drift you in a different direction of dysfunction because we are removing things from the body. So sometimes you got to change the strategy. If I'm getting here to try to solve for blood sugar by like going keto or something, once I solve for that and I got the habits right, then I might have to say, but I also need to get these other macro and micronutrients before I drift into unhealth in a different plane. So rather than thinking about it just like line to line, you start to think about it as like a three-dimensional plane, and the thing that gets me here might start to drift me off in another direction there. So once you hit that goal, okay, I've stabilized my blood glucose, I've got really good habits around eating protein and stabilizing my blood sugar, but then also I want to make sure now I start adding in the things so I don't become nutrient depleted or I don't start having different problems that spike up, anemia, whatever. So it's just a thing to consider for you, adding a little carbs back, a little maple syrup, that seems to do the trick. I found that too. I used to eat, when I was doing a lot of CrossFit competitively, I was working out a lot. I was eating like a paleo diet, that's kind of the standard for that. But then noted that actually I started to get changes in my thyroid hormone outputs because I wasn't getting enough carbohydrate in relative to the amount of work I was doing. So I had to start adding in more complex carbohydrates. It didn't actually feel any better from a performance standpoint, but it helped me in other areas, being able to sleep a little better, to be able to recover a little faster. My brain stayed sharp longer throughout the day, like stuff like that, where, it worked for a while, but then would start to deplete and get some changes. So same way you can apply that on, like, if you're working at a high level, it also probably has You can probably notice it even more when you're trying to get your health back, where those things make a bigger difference. Okay, Cameron Y. She says, looking forward to visiting soon. Awesome, love it. Can you discuss the potential autoimmune connection to dysautonomia, especially after virus or surgery? Yeah. So we just talked a moment ago about hypersensitivity versus hyposensitivity, right? So I'm too responsive to something, I'm not responsive enough. Hyperkinetic versus hypokinetic. Kinetic is like movement, right? So overactive movement responses versus underactive movement responses. If you can think about a muscle as having hyper or hypokinetic or hyper or hypotonic, you can also consider like the immune system is an output from the brain, just like using your muscles, just like speaking, moving your eyes, beating your heart, constricting your blood vessels, activating your organs, and also activating immune tissue, right? So being able to generate immune responses from the brain, being able to convert blood cells in the spleen and in the bone marrow, right? These are all active processes. So if I create a system that is hypersensitive, then it's going to be too responsive to inputs into the body. And this is where we get our immune system is too active toward things it shouldn't be active toward, right? So we have this hyperactive response. Whereas we can see the opposite of that is where I don't respond well enough, and then I don't actually get sick, but then when I'm able, like, I will have problems that start to develop because my body doesn't fight them off. So we see that there's this spectrum of things that can happen. We see a lot of evidence where people after brain injury will start to develop sensitivities and autoimmunities where the immune system becomes too active. So one of the ways that we approach it is we look at it in the conventional terms as well, heredity, lifestyle factors, all of those things. But also we take into account what's happening as we're looking at a problem that is presenting, saying, I have a problem in my brain. It would be silly to say like, well, that problem in my brain has nothing to do with my immune system. So that immune system is a function of the sensitivity and output of the nervous system. So if we have a body where I'm having autonomic problems that may be hyposensitive, hypoactive, then I may see a correlate with what's going to happen with the immune system. So we want to look at them not as separate functions, but we want to look at like how are they overlapping and how are they integrating with each other. And I think that is a way that is useful to look at it. And then we're not running around trying to squish the immune system as a separate job from dealing with heart rate responses, and then we kind of get all over the map trying to chase them around. Okay. Sandra says, hello everybody. Can dysautonomia and neuropathy could be together with peripheral nerve neuropathy? Could you explain? Yeah. So an autonomic neuropathy and peripheral neuropathies can both occur in the same people, and they can be correlated because of the fiber types. Autonomic nerves are skinny and don't have much myelin. No myelin, really. Small diameter sensory nerves, also very skinny, small, no myelin. They're more sensitive to immunological responses, inflammation, compression. These things can tend to irritate or injure those nerves. So there's a lot of crossover between small fiber neuropathies that affect the sensory system and small fiber neuropathies that affect the autonomic motor system. And that's where those two things can tend to correlate. Melissa, hola! I thought you were going to bed. Hopefully you're sleeping. Nomad over normal. Where do you get the latest papers and studies? Is there a Google Alerts equivalent to stay on top of things? There is, actually. You can set up Google Alerts. There are all sorts of little publication things that you can look at. What's mine called? I'll give you a little hot tip at the moment. I use Feedly, Feedly. In my Feedly, basically I go in and subscribe to these different journal articles in PubMed, and then I subscribe to like other publications that also curate them, so that I can see like kind of what the top ones are, and then I can go find them, and then you go into PubMed. You can also use alerts, so you can use them in Google, you can use them in whatever browser you use, or you can use them in RSS feeds from the journals. And it's just like old school blog days. So when a journal pops up, you can actually, a lot of them will like let you pick the things you're interested in, and they'll just send you in an email like, ping, here's an article that's come up. So I get those. We kind of look through the feed every morning, and I kind of pick my favorites to look at, which is cool. It's a good way to stay on top of it. So I read like I ask other people to do brain exercises. If you do it consistently, if you spend years and years and years doing it, you get to read a lot of stuff, and I think that that's been really useful. So Feedly is really cool. You can get some articles there. You can also set up Google alerts. That's really helpful. But just pick the things that first of all, this presumes that you like to read. Number two, if you do like to read and you are interested in this type of literature, then you can search for them. What I would actually start with is going in and reading the old stuff first, not just necessarily the new stuff. Some of the old stuff gives you the most input because people are trying to use their words to explain things that we're not just relying on like instrumentation to see. They're things that people observe and they talk about. So when I start studying a subject, a lot of times I will start trying to go back as far as I can and see where the ideas originally came from, what made them think of that, and then how does that idea evolve over time. And that has been phenomenal for understanding like so many things. It makes me, it makes me think about Roger Dampney and the studies with the dogs in Iowa, not Dampney's, different studies. Then it makes me think about Wilfried Janig's work with autonomic systems, and that guy was an animal, and like all the depth that they went through. And then that helps you come to realize like things that got skipped up along the ways, things that we forgot about. Hey, maybe we should go back and talk about this. And so sometimes like the new stuff is on like a little side quest that isn't as useful. And actually the old stuff is some of my favorite. Rivik said, I used to get chilblains as a kid. Would that have predisposed me toward getting POTS as an adult? I don't think that is probably the thing that caused it, but they are things that tend to overlap just with circulation, particularly in the hands. Out of curiosity. Okay, we're getting into some garments here. All right, you guys can go nuts on that. I'm not going to comment anymore. Austin G says this is 2 a.m. in the UK. He's got to catch the recording tomorrow. Hopefully we got your questions answered. Get some sleep tonight. All right. Okay. Nicholas is asking about, I said, I mentioned that I rarely sleep with my head on a pillow. It's like my body wants me to be completely flat. Would you theoretically expect this to get better with better perfusion? You may or may not. I actually also sleep, you would die laughing if you saw my pillow. I'd be embarrassed to show you. I sleep almost flat. I sleep on a down pillow that is basically flat. I just kind of crunch it up enough so that my head stays pretty level. At this point in the game, I don't know that is like the thing to solve for. As long as you're not waking up feeling gross, you're able to like feel okay in the mornings, and that's what I would start with. Danielle though follows that up, says same here. Unfortunately, my default is on my stomach, so I wake up with neck issues and paresthesias in my arms. Danielle, that is a tell. That is a tell that we are squishing some stuff that shouldn't be squished. Maybe we try to find you a little bit of a different way to sleep. Then Nicholas says, he says the same thing. If you guys got stuff falling asleep on you, you got tinglies and stuff, we got to move you around so that you're not compressing things, okay? All right, start there. No nummy tinglies, no pain, my eyes shouldn't feel weird or dizzy. Okay, so try to get into a spot where you're kind of as neutral as possible. Okay. Oh, Mallory. Mallory says videos were a first introduction to functional neurology as a treatment for POTS. Wonderful. Love that. First appointment with a chiropractor specialized in functional neurology today. Thank you. I hope it goes great. I hope it's a huge win for you. And Melissa was asking about the relationship between POTS and histamine, if any. They're going to correlate in terms of what we talked about just a little bit ago with the immune responses, where we think about hypersensitivity and hyperactivity, hypo, right? So too much or too little. So these big histamine responses are an example of like too big of a response to the environment that we're in. We want to understand what that means. Some people that looks like allergies, right? And some people that looks like other things. But that's a form of that immune activation. Oh, I got the Seed Mans in the house. Love it. If you guys need to buy some good old-fashioned agricultural seed, talk to Jacob Leach. He'll hook you up. Okay, I'll take this one. This will be my last one tonight, and then I'm gonna park it. I gotta get up and build some more chairs tomorrow. This has been a lovely week off. Nicholas says, I wonder what your view is on dealing with the quote-unquote trauma post-recovery from POTS. Do people just forget? I presume that with a lot of patients maintain the fear for a little while, certainly during stress. It's just like anything else. So, okay, so I had an experience where I was having some problems with my heart. I'm not going to talk in depth about it, but I'll give you the basics. Where it was arrhythmic for a long time and it was very symptomatic. And I would feel it constantly. You feel like skip beats in my chest. I can feel them rapid beats. I can feel the change. I was aware of it all the time. And I didn't feel well. It's like a year. I didn't do well. But it constantly had me checking my pulse all the time. And so I ended up needing to have a surgical intervention. So I did. And I had to fight for that, actually. It was, I had to work really hard to get the surgeon to do it. I took in a ream of papers and this is like, for what I have, this is the solution. They didn't want to do it. So I am just as vigilant in that direction as I am in the functional neurology one. If we can find the solution to the problem, let's do that thing regardless of what it is. Okay. So anyway, so I did that. And then afterwards, it was great. My heart did way better. I felt better. But for months after that, all the things that would normally have been like, oh, this is going to bring, oh man, I'm going to go into arrhythmia here and be checking. Or I'd like sit funny in the car for a while and I'd get tight in my chest and I'd be checking, it's fine. So I did that for months, starting to work out again, starting to go into heat again, starting to drive again, going into Costco, all the things. And I would check and I would just kind of be like, is it going to happen? I lay down at night, is it going to happen? And I did that for months. And I used the analogy of the amygdala. Your amygdala's job, people talk about it in pop culture all the time. It's a simple job. The job is to just tag how emotional you should feel about any event during the day. So, and you just kind of like hold up the cards, right? And you score it 0 to 10. That's arbitrary, but it's kind of what it does. 5 is like, there's no real emotion to it. You should probably not put a lot of weight on this. You'll probably forget about it, right? That's like a lot of your life. 10 might be like, I love this so much. I want to seek out doing this as much as possible. This is the thing I want to do with my life, right? So anytime you experience something like that, your amygdala is like 10, and it says like, I'm going to look for that in my life. Remember that, because anything that looks like this situation again, we want to try to do that. And then on the other side is like a 0, where it's like the opposite, where it's like, no matter what, I never want to do that again. I'm going to be super vigilant about it. I don't want to be anywhere near that ever again, forever. And I'm going to be really vigilant about anything that even looks like that. So if you start to have experiences that are like sub-5s related to simple things in your life, getting up, walking around, laying down at night, going to work out, going to class, getting in a car, going to Costco, getting upset, getting excited, any of those things, right? Then you start to notice like, oh, now my body is like, I am vigilant and scared about these things. And so the way I talk about it with people as a metaphor is to say we need to do those things and then have them be 5s or even a 6 or a 7, where you start to go like, hey, that happened and I didn't feel that. That's great. And once you start to notice them, or like, it didn't happen, how awesome is that? And you just call attention to it, then it starts to take like the overall weight and starts to move it back up toward a 5 or even higher, where it starts to be a good thing again. And then you kind of forget about it, right? But there is a period of time there where your body should be nervous about it, right? Like if the last time you rode a bicycle, you crashed it into the wall, you're like, when you come near a wall, you're like, all right, don't do that again. But then after a while, you get like, you go through 10 or 15 walls that you don't hit, you kind of stop paying attention to it as much. And that is like my simple dumbed down metaphor of how I think about that and what I experienced in my life and what I watch people go through all the time. And we did a couple interviews, it's been years ago now, probably 3 or 4 or 5 years ago, where we went back and talked to patients after they hadn't seen us for 2 or 3 years, and almost all of them noted that, where they said, I found myself looking for it, playing my violin, I'm expecting the spasms to come. And it just took a long time. It took a little while before I was able to like stop remembering to think about it. And that is a kind of a constant conversation that's being had. But unfortunately, me telling you about that doesn't make it go away. You still have to go through it and feel it. But the recommendation that I would give, like the doing part, the action that you can take, is that if you notice that there is a thing that used to make you symptomatic, and then it happens, you do that thing and it doesn't make you symptomatic, if you just call attention to it, that is a huge win, because it starts to teach your brain to look at it differently and starts to discharge that amygdala response. So you say like, oh, I walked around the block today, I expected like I might feel bad, I did not feel bad, that's great, let's see if I can do it again. And then you just kind of keep working it through, but just like out loud, even just talk to yourself about like, that's great. I used to do it when I would work out, because I went so long with not being able to work out, and I would get back into it and I sucked compared to where I was before, and it was very frustrating for me. But what I would do is I would do my workout, even though it wasn't what I used to do, I would smile and say, but at least I got to do it today. And then that little thing for me, at least I got to do it today, was enough to keep me going and keep me building through it, even though it was a slow build. So anyway, I don't know if that's helpful for you, Nicholas, or not, or if it's helpful for anybody else here. Those are just some experiences and observations from my life, and hopefully they're useful for you guys. I got through some questions. Mathieson, I'm sorry to hear that you're not feeling great tonight. I just don't have to deal with my usual spamming, lol. I'm going to answer this because Mathieson's always here, and he gutted out this one. What would cause someone to suddenly develop a new type of visual aura, and what could explain it if that aura is followed by a feeling of heaviness and slowness in the head, arms, and one leg? Almost like shutting down. I read online that one explanation could be electrical activity, but I'm not sure exactly what this means in this context. So if that is happening, a new type of aura, anything that's new in the head pain or the brain area, you want to take note of it. Sometimes there are things that are emergent, you want to get checked out, get the MRI, do the things, especially if you're nervous about it. That's like the general emergency thing to think about, right, if you're worried. But then also, if you're noticing that it's on one side, this is not medical advice for you, this is how people could think about it. Electrical activity can be slowing down, but then the question is, why is the electrical activity slowing down, and why is it relative just to certain areas? Visual auras, could they be in the eye? Yes. Could they be in the projections of the Meyer's loops? Yes. But are they more common in the occipital lobe? Yes. So if we're noticing those, that's a consideration. And then we want to think about, is there anything that's just creating a migrainous type of vasospasm? Is it something that is compressive? Hopefully not, probably not, but that's the thing to think about. Or are we looking at like other parts of the history that we need to talk about? So changes in auras, changes in sensation, always rule out the worst, and then you can start working backwards to try to figure out what is the problem we need to solve for. Is it electrical? Is it plumbing? Is it a problem with just simple structure? Is it strain or stress? Like, then you have to go through all the history of what's going on. But hopefully that's useful for you guys. It's 10 o'clock. I've got to hit the hay. Loved having you here. I love doing this even though we got the big 4th of July tomorrow. I hope you all find a way to have a great day. Maybe we start putting into play some of these exposure to heat techniques. But most of you, I'm just going to really implore you, if you're interested in something like this and you're trying to figure out the problem for you, take the steps to figure out what the underlying problem is. It's going to be the thing that makes the biggest difference in your life, and that's how we get out of these things. So good luck to you guys. I'll be thinking about you. I'll see you next week. Take care.